Medical Notepad brought to you by Cardiovascular Systems Incorporated's Patient Advocacy Campaign, Take a Stand Against Amputation, and The Way to My Heart.
My name is Anaita Dua. I'm a vascular surgeon at Mass General and director of our Limb Evaluation Amputation Prevention Program.
How do you know if you are a right candidate for a bypass? And number two is, how do you choose the vascular surgeon for the bypass?
I'll start out with the first one about choosing the vascular surgeon. In order to have a good bypass, you need a variety of factors. Number one, of course, you need an excellent surgeon. You need someone who cares about you and someone who knows what they're doing. Number two, you as the patient need to have some factors that are going to make a bypass more likely to work. Number one, things that you can control. That would include taking your medication, so your blood thinners, after the procedure, taking good care of your incisions so that they don't get infected, and doing things that the doctor tells you, including having the right nutritional choices to heal up these big wounds, and walking so that you get that blood flow moving. Okay, so these are things you can control that you need to optimize. Now, things you cannot control that are also fundamentally important to a bypass being successful include having the right conduit. The ideal situation is that there's a long, juicy, thick piece of vein that we can use to make that bypass happen. But if you are a patient that has potentially had a heart procedure in the past where the vein has already been taken, or you're a patient that had had venous reflux in the past and the vein has been eradicated as part of your venous treatment, these are situations where you simply will not have the vein that we would be able to use to do the bypass, and we will have to use prosthetic, which already reduces the chances of the bypass staying open long term by a little bit and increases the infection rate. But of course, if you don't have vein, you don't have vein. The other really important thing about you as a patient is in order for a bypass to work, you have to have inflow of blood and you have to have outflow. So think of a highway system. Let's say there's a car crash on the highway. What does a cop need to do? The cop needs to detour the cars from where there's good road, no car crash, to where there's good road down here, again, no car crash, around the area of the car crash. But imagine if someone just bombed the highway. Now the cops have nowhere to detour those cars because there's nowhere to go. What's happened is, over the last 30 years, because of diabetes, because of smoking, because of end-stage renal disease, patients have gone from having good highway, good blood supply here and good blood supply here, where a doctor could do a nice bypass, to a situation where there's basically carpet bombing of all the blood vessels from the knee down to the foot. So the problem then becomes, I have nowhere to bypass to. In order for a bypass to work, you have to have inflow, outflow, conduit. Conduit is the vein or the prosthetic. So the reason the bypasses are failing is not because there's a technical situation, not because the vascular surgeon's not good, not even because the patient's not doing what they need to be doing. It's because nowadays, because our medical therapies are so good, because people are living longer with diabetes, we are now seeing the eradication of the outflow blood vessels from the knee down to the foot, such that when you do a bypass, blood gets into that bypass. Everything's great up top. But when it gets down to, let's say, mid-calf, where we've done the connection, maybe the bypass stays open for a couple of months, but then the disease process that got you there in the first place, that's still going and knocking off those blood vessels that's down by your foot. And ultimately, blood is pretty stupid. Blood does two things. It flows or it clots. So if it's not flowing, it's going to clot. And so if you have a blockage beyond where your bypass is connected and blood has nowhere to go, it's going to stagnate and it's going to clot off. Now, when you have a prosthetic bypass, one of the benefits of having plastic is that I can go in there as the doctor and suck out that clot and shove things in there and put a lysis catheter in there to clot bust this and try to get the bypass open. When you have a vein bypass, because it is your own body, when there's clot in there, that clot's like gum and it sticks to the side of the vein, and it's real difficult to go in there and get the clot out without damaging the inside aspect of the vein, which causes clotting to happen again. So doctors have shifted their thinking from simply, hey, I want a bypass that's going to last 10 years, to I want to get some blood down to the foot to heal your wound. Because if your wound heals, and then let's say your bypass shuts down, at least I've healed your wound and gotten you back to some sort of basic livable situation. So in terms of picking the vascular surgeon, it's not that simple. It's not that the bypass is not working because your vascular surgeon is bad. Not at all. If it's a vascular surgeon trained in appropriate program, that's going to be a person that knows how to do a bypass. That's going to be a person that can do a technically sound procedure. But the problem is the technical aspect of it, albeit incredibly important, is not the only reason why a bypass goes down. So actually, I would advise the most important thing that a patient does is take that time talking to the doctor about, talk to me about my inflow, my outflow, and my conduit. Talk to me about these three things. Because if these three things are optimized, you're going to get the doctor saying, oh, you're going to be great. You got a beautiful, juicy piece of vein. You have a nice, thick artery up here with good blood flow. You got a nice area that's a good target down below. You're going to be wonderful. Or the doctor is going to say, hey, great question. Actually, I'm going to have to use prosthetic on you. This is why. You don't have vein because of this, this, this. And down below, here's your angiogram. Down here, look, there's not much area for blood to go. Probably do a good bypass on you, and my hope is it's going to stay open X amount of time. These are the things we can do to optimize that. I'm going to put you on full dose blood thinner. I'm going to ask you to walk this much. I'm going to ask you to get this type of wound care, because remember, what's happening when the bypass goes down is clot. Clot forms for a variety of reasons, one of which is the hypercoagulable state, the hyperclotting state that you get when you're infected. So if I have done a vein harvest and taken vein out of your opposite leg, and you as the patient don't do what I say in terms of taking your antibiotics and in terms of keeping that incision clean, now you get pus coming out of that incision that makes your whole body inflamed, and you clot off your bypass graft, even though everything is perfect. So there's a variety of pieces, and your vascular surgeon's job, aside from the technical side of things, is to optimize your story to get the most chance that that bypass is going to stay open.
Remember, the advice and views offered during this series are for informational and educational purposes only. Always ask your own healthcare provider for explicit consent before acting on any information provided here. If you want more information on peripheral artery disease, go to standagainstamputation.com. And for real-time support, go to thewaytomyheart.org.